Hello. Good afternoon. Can somebody confirm that you can hear me?
Yes.
Hello?
Hello.
Yes, we're able
We
to hear
can
you.
hear
Can
you.
hear you, sir.
Okay, all right. Who is this I'm speaking to?
Tamara.
Okay. Sorry for starting late. We had a meeting in the department, so that's where I was held up. Nevertheless, I think I feel it's prudent that we continue with this lecture. At this time, I'll be very quick. Hopefully, we can finish within 45 minutes. Hello?
Yes.
All right. Can you nominate one person at least to be making sure that I'm audible? If there is a problem, they tell me. Then before we open up the lecture for questions.
I can do it.
Okay.
Tamara.
All right. Let's ensure that our mics are on mute. And I'll be beginning with the lecture. As you can see, are you able to see my PowerPoint on your screen?
Yes. Yes.
All right, thank you. Thank you. So this, I'm Dr. Nyimbiri. This lecture was given some time back this year. I didn't have an opportunity to edit it. I'll just give it like that to your course coordinator. So today we are going to discuss diseases of the pancreas. I can get some feedback from somewhere, but somebody has to check their mic and make sure that it's on mute. Okay, that's much better. I think somebody just joined us. Okay. So this is our outline. Okay. So our outline is as shown on your screen. We're going to have a small introduction, then go through the embryology, anatomy, physiology, and congenital anomalies. Then we'll look at the acquired congenital diseases of the pancreas. So in the embryology of the pancreas, we know that the pancreas is formed from two buds which originate from the endoderm lining the duodenum. There's a dorsal and a ventral pancreatic bud. These
sorry, sir, can you please share your screen? Can you please
at some
play your
point and
slides?
fuse to answer process. Hello?
Sorry to disturb you, sir, but can you please play the slides
What
so
are you
that we
saying?
can see? Can you please play the slides so that we
Hello?
can see them? Can you please play the slides so that we can see them nicely?
Are you able? You want me to enlarge them?
Yes.
I'll try. Are you able to see my slides?
Yes.
Yes,
Yes.
thank you very much, sir.
All right. Okay. So I was saying we are discussing the embryology of the pancreas. It's formed from two parts. These are originate from the endoderm lining of the duodenum. There's a dorsal and ventral pancreatic bud, the whole pancreas. The ventral
We cannot hear you. Right corner.
No, just clicking on the slide share there.
I'm saying if I enlarge the PowerPoint, I'm losing you.
No, I'm saying, what about just making the words bigger and not taking it to play? Zoom in the picture. Always. At least better.
Okay. It's better.
Yes.
Okay. How about this?
Better.
Okay. All right. So I was saying the embryology just shows you, this picture is just showing you the way the dorsal and the ventral bud move and fuse to form the pancreas. Like I had said earlier, your ventral bud moves and forms the ansnet process, and the head. Then the rest of the pancreas is formed from the dorsal. Then the duct system will fuse depending on the way they fuse. Sometimes you can have two, the main pancreatic duct and an accessory duct. Okay. So we know that the pancreas is a retroperitoneal organ. It extends from the duodenum to the splenic hilum. Has a head which is about 30% of the gland by mass, and the tail which constitutes 70%. And it weighs approximately 80 grams. That's just the gross anatomy. Just so that's for you guys, you have an idea of what we are talking about. So this picture just shows you the relationship of the pancreas. I hope you are able to see this, the tail there, neck, head, and its relationship to the This is the duodenum. And it's also intimately related to the superior mesenteric artery and the vein. And you've got your splenic artery just superior to it. Okay. So we know that 80% of the pancreas is an exocrine gland, and it has got clusters of Langerhans cells scattered through it. Then 75% of the islets are composed of beta cells, which produce insulin, and 20% are alpha, which produce glucagon and all those other hormones. We know that B cells form the inner core and surrounded by the other cells. So I had mentioned earlier on the ducts which drain the pancreas. There's a main duct and accessory duct. These are joined into the duodenum at the ampera ovata, which is a common channel with the pancreatic duct and the biliary tree. Okay, this picture just shows you the anatomy I was just talking about, where you have your duodenum, common bile duct coming to drain, and the main pancreatic duct forming. This is the ampera papilla ovata. Then there's an accessory duct. Okay. Let's go into the meat for today. So, what are the conditions which can present the pancreatic disease present to the general surgical department? There are so many diseases of the pancreas, but we will need to highlight common ones, or those which are of surgical importance, those we commonly see, so that we can discuss those in brief. So there are many congenital anomalies which can arise from the embryology of the pancreas that we had just described. And those which we encounter in surgery include just variations in the way the things form as they are developing. So there could be variations and anomalies of the ducts, or you can have variations resulting from the rotations of the buds themselves. So variations to the ducts will produce most of the time a pancreas diversum. Then you can have an annular pancreas where the tissues, as they are migrating, encircle the part of the duodenum, the third part, second part, I think, yeah. Then that causes an annular pancreas. Then you can have polycystic disease, congenital pancreatic cyst and cystic fibrosis as the developmental diseases which present with the pancreas. Sometimes you have ectopic pancreatic tissue and accessory pancreatic tissue which can cause problems. Related to this, you can have colorectal cyst because they're developing in the biliary tree. This sometimes can be confused with can present together with some conditions in the pancreas. Okay, then you have got lesser known conditions where there's aplasia, hypoplasia, hypertrophy, dysplasia. These are just common things which can happen with development. A horseshoe pancreas is where the anterior and ventral bud fuse. I think both of them in anteriorly below the superior mesenteric vein, giving like a horseshoe appearance around those structures. So let's add a little bit of detail to what we are discussing. So failure of the dorsal and ventral bud pancreatic modules to fuse will result in a divided pancreas. That's what just this it means. So this will result in separate drainage ducts of Wisong and Santorin. This happens in about 3% of the incidence is about 3% of the population. We have to know about this because most of the time this leads to chronic pancreatitis in most of the patients who have this condition where you have got two independent ducts draining two parts of the pancreas because of the failure of fusion of the dorsal and ventral buds. The studies have shown that commonly in these patients, they tend to develop chronic pancreatitis as a result. The reason for that, we don't know. So this picture or this slide just depicts an annular pancreas. This results from failure of complete rotation of the ventral pancreatic bud during development. A ring of pancreatic tissue surrounds the second and third part of the duodenum. As seen here in B. I hope you can see my pointer. The picture on the top shows the normal development. The picture below shows an abnormal development where you've got this brown-like structure around this tubular structure, which is the duodenum. So this can lead to obstructive symptoms of the duodenum, and sometimes patients can present with intestinal obstruction in children or maybe in infancy. Or sometimes it can cause mild symptoms, vague symptoms, and present later on in adulthood. It's commonly seen with congenital duodenal stenosis or atresia, and it's common in patients with Down syndrome. Okay. This is a gross picture, or it's a pictorial depiction of annular pancreas, where you have, here's a stomach and duodenum. They're just pictures trying to demonstrate the same thing. It's not uncommon to have ectopic tissues. These can be found of pancreas. These are commonly found in parts of the stomach, the duodenum, and small intestines. And sometimes you can find them in Meckel's diverticulum, and sometimes can lead to bleeding if they are found in the Meckel's diverticulum, pancreatic tissue or intestinal tissue there. It can lead to some severe bleeding because of the enzyme they produce, and those can cause injury to the mucosa of the tissues in the Meckel's diverticulum. The gallbladder can also be a site of this ectopic pancreatic tissue. The others are just rare sites. It can, but if you have seen, most of the areas where commonly you find ectopic tissue are those areas near the pancreas or those adjacent to the pancreas. So acquired abnormalities of the pancreas are many. You can have trauma to the pancreas, inflammatory conditions to the pancreas, tumors, but of surgical importance, I think what we are going to discuss is pancreatitis, maybe CA pancreas and the way it presents. if we were to go into each and every disease that can possibly present from pancreatic tissue, this lecture would take longer than, and it's not possible to have it in an hour. The idea here is to have you oriented towards common conditions which you're going to face in the Department of Surgery. So acute pancreatitis is a common condition we see in the department. So this is just inflammation of the pancreas. And the underlying thing here is that it's a reversible pathology where there's acute injury to the pancreas, which leads to inflammation, and that injury is reversible. Chronic pancreatitis, on the other hand, is just inflammation which is associated with permanent derangement of structure of the pancreas and function. So in chronic pancreatitis, because there's chronic inflammation, this leads to healing by fibrosis. So there is permanent derangement or alteration to function and structure. So that's the difference between acute and chronic pancreatitis. So now we're going to talk about acute pancreatitis. It's a common condition which presents with abdominal pain and is usually associated with raised pancreatic enzyme levels in blood or urine. Is associated with inflammation and has a male to female ratio of 1:3. You might be surprised as to why more women are affected. These statistics most commonly are from the Western world. And in women, if there's acute pancreatitis, most of the time it is associated with gallstones. That's why you see this to be high, 3 times more in women than in men. From my experience here, I think the incidence is, for us, I think it's a bit more in men than women. I think ours is alcohol related, alcohol abuse related as a cause. So it may occur at any age with a peak in young men and older women. Causes are non-traumatic in 75%, traumatic in 5%, and idiopathic in the remaining 20%. Acute pancreatitis can be mild or severe. That's how you can classify. So this picture just lists the major causes or predisposing factors that lead to acute pancreatitis. In the non-traumatic cases, the major factors that you have that predispose to the disease or precipitate acute pancreatitis, the 2 major ones are biliary tract disease, that's stones, and alcohol. Those are the 2 major factors. Then there are the minor conditions. You can have viral infection, such as mumps and Coxsackie B infection. Drugs, steroid drugs, containing drugs can also cause or precipitate an episode of acute pancreatitis. Hyperparathyroidism, hyperlipidemia, hypothermia, and some special scorpion bite can cause that. Patients with CA pancreas can also present with pancreatitis. You can have patients with polyarteritis nodosa or previous poria gastrectomy. These are conditions in which acute pancreatitis can present. Then in the traumatic side, and there is operative trauma. When you're operating in the area near the pancreas, you can need to an acute inflammatory process in the pancreas. Blunt abdominal trauma, when there's injury to the pancreas, that can lead to acute pancreatitis. Or more common in these days, when they are doing procedures on the pancreas, such as ERCP, where you use an endoscopy to investigate the patency of the biliary tree and pancreatic ducts. That manipulation can lead to acute pancreatitis. So the rest of the cases, like in about 20%, it's idiopathic. That means we do not know the cause yet. So in acute pancreatitis, what happens is that like in biliary stones, the theory is that there is blockage of the ampulla ovata, and that causes stasis of the pancreatic enzymes which are being produced and excreted through that duct. And because of that stasis, there is actually activation of the enzyme in the pancreatic duct, leading to the enzymes starting to digest the pancreatic tissue itself, because those most of the proteolytic enzymes in that. And once that process starts, creates a cascade of events where you have activated enzyme digesting pancreatic tissue, then there's leakage of enzymes from that pancreatic tissue which become activated, and the process goes on. That leads to inflammation. So if you have seen, like for stones, operative techniques, most of that is because of the procedures which cause, when you intubate the duct, the spasm which are caused, that might lead to stasis and sort of precipitate the activation of the pancreatic enzymes. Are we together?
Yes.
Yes.
Okay, this is very strange. You can be talking, you're just alone. Okay. So some people tend to have what they call a hereditary pancreatitis, where you have recurrent severe episode of pancreatitis, those which begin in childhood. Most of them are due to genetic mutations. Trypsinogen gets activated within the pancreas easily in these guys, and they tend to present with this. They'll probably end up with chronic pancreatitis because of the repeated recurrent episode of pancreatitis. So the basic alterations are that there's microvascular leakage causing edema, inflammation, necrosis of fat by lipolytic enzymes, then there is acute inflammation. This is what happens when the enzymes are activated, actually. So the proteolytic destruction of the pancreatic parenchyma and destruction of blood vessels and subsequent interstitial hemorrhage. This is the process of inflammation that happens in the pancreas. Injury to the blood vessels will lead to necrosis of the tissue. So in severe pancreatitis, there is actually necrosis of the pancreatic tissue, and sometimes the surrounding tissues, the omentum can be damaged as well. So This picture just depicts what happens, the pathophysiology of acute pancreatitis. The font is just too small. I hope you're able to see. So that it can be duct obstruction or injury to the ancina. So drugs, alcohol, and trauma, ischemia, and viruses, they injure actually the ancina, while these others are obstructive. So the precipitating event can be an obstructive one or injury to the ancina that produce the pancreatic enzymes. Or there could be a defective intracellular transport system leading to metabolic injury as a result of alcohol or duct obstruction. So there are three precipitating events, but all of them ultimately lead to ancina cell injury. Then the ancina cell injury leads to inflammation and leakage of pancreatic enzymes which become activated. Can't seem to move this slide. Okay. And that leads to the inflammation which I had previously described. So what are the clinical features of acute pancreatitis? So the main presenting complaint of the patients with acute pancreatitis is abdominal pain. Most of the time, this pain is referred to the back. This is because, as we had seen in the anatomy, the pancreas is a retroperitoneal organ. So the pain will be referred to the back. Back pain, which is most of the time epigastric and referred to the back. They also tend to present with anorexia, nausea, and vomiting. Jaundice may be a feature, especially if the patient is presenting with an obstructive symptom or has got some stones. Those stones can cause obstruction and cause jaundice. The other reason is with the patient has got severe pancreatitis, which has resulted in injury to the liver. That can present with jaundice as well. The other things you will be able to note if you do your physical examination is that the patient can have a gray turners or curl inside. These are just subdermal hemorrhages, but we should note that these signs are not pathognomic of pancreatitis. Anything which can cause bleeding under the skin will give you those signs. So when you do your investigation, you will find that your white blood cell count, as a leukocyte count, is high. The HB might be low because of hemolysis, and the patient can have features of DIC. Because of the inflammation in the retroperitoneal space, sometimes there is extravasation or third spacing of fluid. Fluid moves into this interstitial space from the vessels. And because the communication between the retroperitoneal space and the chest cavity through the different planes, the enzymes can seep through and go to and injure the lungs and lead to an acute respiratory distress syndrome. Because of third spacing, you can have vascular collapse and shock because fluid is moved from the interstitial space from the intravascular space into the interstitial space. And this can lead to renal tubular necrosis. So this is just a pathophysiology of the clinical picture. So these are the pictures just showing you some of the things you will see. Okay.
Excuse me, is that also visible in our patients?
The color.
Yes, like will they also be appearing?
Yes, but it won't appear like this. This is a white person. If you are black, like my friend is very dark, we call him beige. Of course, there will be some color discoloration, but you have to be very observant. If you are on the fair side, it will be easy to see it, but you should be able to see that the skin looks a bit different. Yeah, it depends on your skin tone, but you should be able to see some of these things. These are very clear because of the guy who suffered this was a white guy. Okay. So how do you investigate a patient with pancreatitis? Or how do you make a diagnosis? The most important thing is this will present as an acute abdomen. So a high index of suspicion and a high index of suspicion is important. For you to have a high index of suspicion, your history taking skills have to be good. And this is what you guys must learn at this point. You should be able to elicit your history very well. Epigastric pain, you develop your symptoms, make sure that you develop the character of the pain, where it's radiating, and what else is happening to the patient, for how long. All those things are very important. Because if you do not get a good history, it's quite very common to open up these patients. Because when they present, you think somebody has come with a peritonitis because of the pain and everything. And they will present sometimes with features of overt peritonitis. But if you've got a good history and the high index of suspicion, you can be able to pick it up and suspect, okay, this probably, even if it's peritonitis, most likely is secondary to acute pancreatitis. Then you ask for relevant investigations, and that will help you make a diagnosis. So a good history, good physical exam will help. And once you do that and you suspect acute pancreatitis, it's important that you do a serum amylase. The levels will be elevated for between day 4 and day 18. So most of the time, our patients, when they present, their levels will be high. Another thing of note is that a normal serum amylase level does not exclude the diagnosis of acute pancreatitis. It's very important to know that. You could have missed it because the levels sometimes after day 8 start going down. Or sometimes even area, they start going down. So you will not be able to pick it up, especially if you're doing a serum one. Urine takes a bit more longer for it to drop. Then there are certain scoring systems which have been developed so that you can classify your patient in terms of severity. Hello?
Sorry, how about the serum lipase? Since lipase is more specific to the pancreas, what if it is raised?
Even that, you can do that. The problem with lipase, it's a good diagnostic serum marker. But the thing is this, it's not readily available compared to serum amylase. If you can do it, well and good, do it. You understand?
All right, yes, I do.
Yes. So the Ransom's Glaxco these are just scoring systems which help classify the severity of your patients. So you can learn one and use it well. So you can use that scoring system to classify your patient, how severe the pancreatitis is. Ransom's is a bit more complex because you have to assess the patient on admission, and is it 48 hours later to see how they have progressed. The Glasgow scoring system is a bit more user-friendly because it's just you administer once on admission, that's it. So you can do imaging studies as well in this patient where you do contrast enhanced CT scan, MRI, routine bloods, plain chest, abdomen, ultrasound, just to support your wake-up. Also note that when you do your serum studies, if somebody has got hypocalcemia, that is a poor prognostic score. The outcome usually are not good in patients who present with hypocalcemia. So this is the Glasgow score and its parameters. It spells the name pancreas actually. The acronym for Glasgow, parameters can spell the name pancreas. So you have got the partial pressure of oxygen, the age of the patient, the neutrophil levels, calcium levels, renal function, enzymes, that's LDH. Then you can think of the albumin level. And the S is serum glucose, I think, yeah, which is sugar. Oh, wait, what have I done? Okay. This is this sugar. That's a serum sugar level. If somebody has a raised serum glucose level, or what you call just diabetes at presentation, or sugar above 10, you know that the injury to the pancreas is so severe that the insulin production has been reduced, or the inflammatory acute phase inflammation is so severe that there's poor utilization of sugar. So how do we manage these patients? I know it's not at this stage, this is not the most important thing for you, but it's better you have an idea of just the principles. So management is just conservative approach where you give IV fluids, keep the patient NPO, you give them analgesics, you can give some antiemetics, you can admit this patient to a high dependence unit if it's severe, or here in our case it's ICU, but then you IV antibiotics you can give, but this literature doesn't seem to support the routine use of these IV antibiotics. Unless you think there is infection. If it's just inflammation where you don't suspect any infection going on, or the necrotic tissue hasn't become infected, or then the use of antibiotics is not encouraged, especially in mild to moderate cases of acute pancreatitis. You just do the other management, analgesia, NPO, antiemetics, then you give fluids. Antibiotics only in cases where you suspect that there could be an infective process going on after the acute pancreatitis. So acute pancreatitis can have systemic complications. If you saw from the acronym, the things you are measuring from calcium to sugar to LDH, renal function, it just tells you that the complication can be multi-systemic. You can have serious complications. You can have pulmonary, renal, hematological, and metabolic, even GI and CNS complications. In the renal system, you can have renal failure. Pulmonary, we've talked about acute respiratory distress syndrome. Hematology, you can have DIC. Metabolic, your hyperglycemia. GI, there could be paralytic areas because of the inflammation and vomiting, all those. CNS, somebody can come in confused because of the toxins produced from the underlying severe acute fulminant inflammation. So there could be also local complication of the condition itself. Because the condition is an inflammatory process, there is most of the time acute fluid collection. And because sometimes pancreatic tissue becomes necrotic, it can become infected and present as an abscess, a pseudocyst, or sometimes it can be just hemorrhagic pancreatitis. Then the inflammation around that region can lead to portal and splenic vein thrombosis. So those are local because these effects are within the region of the pancreas. Okay. So now we'll talk a bit about chronic pancreatitis. I hope you have understood acute pancreatitis or you've grasped what happens in patients with acute pancreatitis. Can somebody confirm?
Yes.
Hello? Or
Yes.
anybody with a question on this? Okay, anybody with a question on this? So that once we move out, we can run through this presentation. I think if you understand the concept there, then for me, I'll be happy.
We are clear.
Hello, I have a question.
Mm-hmm.
Yes, I wanted to find out how's the connection between the pancreatitis and the hemolysis as the presentation, as one of the presentation.
Those pictures I showed, are you talking about the pictures I've shown?
No, like the clinical presentation of the patient where you had listed the things that they might present with.
DIC.
Those hemolysis, so like DIC and hemolysis.
Okay. Yes.
So yeah, like I wanted
Okay.
to find out like how's the connection? How can pancreatitis lead to that?
Oh, how does pancreatitis? It's the inflammation around the pancreas. So those things, what can happen is because of the severe inflammatory process, one, like I said, it can cause thrombosis where there is hemolysis because there is injury of microvasculature in the interstitium. Those will start bleeding. Yeah. So once they start bleeding, that will lead to DIC because you lose not only the red blood cells, but the clotting factors as well, isn't it? Then again,
Yes.
because of the inflammatory process in the small microvasculature, those can cause injury to the red blood cells, isn't it? Then those will become That's where the hemolysis, they will break down because of the enzymes acting on the microvasculature. You understand?
Yes.
So those who injure the red blood cells, because the red blood cells are composed of protein and lipids, isn't it? So they will start
Yes.
hemolyzing. Injury to the vessels plus microvasculature, then that becomes generalized like that. You understand?
Okay,
I
thank
hope
you.
you get what I'm saying. All right.
Yes. Yes.
Okay. So now we'll go to chronic pancreatitis. So chronic pancreatitis, as we had defined, is where there is inflammation which leads to permanent structural and functional loss of the pancreas. So there is loss of the lobules, the way they appear. They will heal by fibrosis. Then there is loss of exocrine tissue, typically initially it's not the islet cells themselves, but with time, if the chronic pancreatitis has been there for some time, some people tend up to lose the islet cells and they end up with the diabetes. So they can be irregular distributed fibrosis. This can present with obstructive symptoms. Sometimes even stones form in the ducts because of the obstruction and the inflammatory process which happens. Later, the pancreas can even enlarge itself and become hard as a result of the fibrosis. Chronic pancreatitis can also lead to pseudocyst formation. And this happens in 25% of the cases. It's one of the common causes of pancreatic pseudocyst. So this patient present with abdominal pain as well, the pain and nausea. There's history, hello? There's history of weight loss and they have steatorrhea. That's they pass fatty stools. There is jaundice. Also, there is loss of endocrine function leading to development of diabetes. That is a later presentation. In the early stages, it's just these other things which happen. So the investigation for you to come up with that, you need to do serum lipase and amylase. An abdominal X-ray sometimes might help because if there's stone formation, you'll be able to see the stones, especially if they are calcium stones, they'll be able to pick them up on a good X-ray in the region where the pancreas is supposed to be. A CT in terms of imaging is better diagnostic for this kind of condition. You'll be able to see the inflammation, the duct, whether they're dilated or not, or they are stones. MRI also will be able to tell you about the same thing. Nowadays, people tend to do an esophageal ultrasound or endoscopic ultrasound, where you put an ultrasound into the stomach and you take it to the duodenum and be able to image the pancreas in the duodenum. If you're good enough, you can even get a fine needle biopsy of the swelling in the pancreas using this same technique. And that will be able to show chronic inflammation as opposed to a tumor or a malignancy in the head of the pancreas or wherever it is. Yes, somebody is trying to say something. Okay. So management most of the time for chronic pancreatitis is in the medical measures. You just sort out if you've got diabetes, you control the sugar, you manage the pain. Endoscopy and radiological or surgical interventions are indicated mainly to relieve obstruction of the pancreatic duct or bowel duct or the duodenum, or in dealing with complications such as the pseudocyst, abscess, fistula, ascites, or various hemorrhage. So this Variceal hemorrhage will result because of the pressure which will arise if there is in the splenic vein. Thrombosis can cause because of the chronic pancreatitis. Sometimes you can develop the splenic vein thrombosis, which will lead to pressure in the portal system and cause varices. So pancreatic pseudocyst is one of the common conditions we'll see in surgery, and most of the time it's a sequelae or a complication of acute pancreatitis and chronic pancreatitis. So this is just a collection of amylase-rich fluid in a ward of fibrosis or granulation tissue. Typically arises after an attack of acute pancreatitis, chronic pancreatitis, or after trauma. Normally requires 4 or more weeks from the onset for acute pancreatitis for it to form. And we do not normally operate on them until after 6 weeks from the initial acute attack and after the enzyme levels have settled. Usually is identified on ultrasound or CT scan. You can do an endoscopic ultrasound and aspirate the fluid carefully if it's small. But if there are necrotic tissues or if you think inside the cyst itself, it looks complex. If it's a simple cyst, you can just aspirate it with this means. That's minimally invasive where you do endoscopic ultrasound and aspirate. But sometimes what we commonly do here, what we have available is open methods where you connect the cyst to the nearest GI organ. The stomach is the most common. Sometimes you can use the duodenum, or sometimes you can connect it to the jejunum to drain it. Once you do that, most of the patients tend to do very well. What is important is that most of these cysts actually tend to resolve on their own. So you shouldn't be in a rush to think of operating or sending the patient on the patient because after 6 weeks, they tend to resolve. You can even give them 3 months to see whether they are reducing. If they are reducing in size, they tend to disappear. But if they can't disappear, it's giving a problem to a patient. It's better you drain it, with whatever means you have available. So complications of pseudocysts include the following. They can become infected, at which point it becomes a surgical emergency because now there's an abscess or whatever has formed in there which has to be drained. You don't have to wait for 6 weeks or anything like that. The drainage depends on whatever means you have. If you have got minimally invasive means, you can do interventional, where you go and drain and suck it out using image guidance, ultrasound or CT. Then if not that, then you have to drain it using open methods. The cyst can rupture, or the cyst can have pressure effects on the surrounding organs, or it can erode into surrounding vessels. I've already talked about the treatments where you connect it to the stomach. They just call that cystogastrostomy. You connect it to the jejunum, it becomes cystojejunectomy. You connect it to the duodenum, it becomes cystojejunectomy. And if you can excise it completely, well and good. You just excise it. Okay, since we are on cysts, another thing we should be aware of are cystic tumors of the pancreas. This is a very important topic because most of the time when we see a cystic mass associated with the pancreas, the first thing we think of is a pancreatic pseudocyst. but true pancreatic cysts do exist. And these are classified, or they are described under the cystic tumors of the pancreas. They are the second most common exocrine pancreatic neoplasms following adenocarcinoma. So there are three types. Cystic tumors of the pancreas. There's a mucinous type. Then there's a serous type. This is just simple. Then there's a intraductal papillary mucinous type or neoplasms. So there's a mucinous, serous, and intraductal papillary mucinous neoplasms. So these neoplasms of the pancreas are very common. Second most common tumor of the pancreas following adenocarcinoma. So the mucinous cystic neoplasm is the commonest among these neoplasms of the pancreas. It has a histological spectrum from benign to invasive here. They contain mucus-producing cells, as their word denotes, mucinous. So there is mucin in the cyst. They tend to present with vague abdominal pain. 20% of them give history of pancreatitis at some point. Hence, they are commonly misdiagnosed as pancreatic pseudocyst. And they commonly affect the body and tail of the pancreas. Then the second group is a serous cystic neoplasm. These tend to affect the head more commonly. And the presentation is similar to the mucinous type. There's just vague abdominal pain, there's weight loss. Sometimes because of the location of where they are in the head of the pancreas, they might present with obstructive jaundice. They are grossly enlarged, well circumscribed masses. Sometimes they might have some central calcification when you do your CT scan with radiation septa giving a sun-based appearance, as if the way you see if you're talking about osteosarcomas. If they have this appearance, then the chances of them being malignant is high when you do CT scan. Generally, they are considered to be benign. So if you're going to choose a tumor to have among these cystic neoplasms, this should be the one you choose, the serous type, because it's the most, the benign type or among those. Then the last one among these three is the intraductal papillary mucinous neoplasms. These are common in the elderly, that's in the 60th and 7th decade of life, and encompass a wide spectrum of changes from benign to invasive adenocarcinoma. They are characterized by extent of pancreatic involvement. The more ducts involved, the higher the risk of it being an adenocarcinoma or a malignant condition. So there's a table I put, I hope. Which gives you the worrisome features when you have got intraductal papillary mucinous neoplasms. So the worrisome features, if the duct in dilatation is 5 to 9 millimeters, you should be worried. If there's a non-enhancing neural nodule, that's just a worrisome feature. If it's thickened and the wall of the cyst is enhancing, when you do your contrast CT, then you know this should alert you. But things which should make you jump and try to make a diagnosis that this probably is a malignancy when you have got this intraductal papillary mucinous neoplasms. When you do your CT, the duct dilatation, the main duct is greater than 1 centimeter, you know there is a problem. If there is enhanced solid components, when you do your contrast, the contrast is picked up by the cyst, the solid component of the cyst, then you know that there is a problem. If there is jaundice, most likely, this thing is a neoplasm. So these are worrisome features which should make you follow up the patient regularly, and high risk features, this you have to make sure that you rule out a malignancy. It could be just that it's an adenocarcinoma which has a cystic feature. So these are the most, what can I call them? These are the most, this type is the one which is highly aggressive among these neoplasms. Most of them tend to develop into adenocarcinomas. In some centers, they even prophylactically offer doing a pancreatectomy partial if you have this condition, because the chances of you developing an malignancy or an invasive process is quite high. So this table just gives you features of clinical features or characteristics of pseudocyst, serous carcinomas, mucinous cystic carcinomas, and intraductal carcinomas, the differences within them. I hope you get a copy of this lecture so that you can go through them by yourself. Then I think this should be the last one, hopefully. Carcinoma of the head of pancreas. It's a very important condition. We commonly see these patients in our patients. But from literature, worldwide, it constitutes 2 to 3% of all cancers. And 85% of all cancers of the pancreas are ductal adenocarcinomas. The rest, we've got some endocrine tumors of the pancreas that can present as well, but most of them are adenocarcinomas. It arises commonly in the head of the gland. Then the ducts tends to, this carcinoma tends to commonly infiltrate locally first. Liver and peritoneal metastases are very common. Then cystic tumors of the pancreas may be the presenting feature of this as well. Serous or mucinous will present as some of them will be adenocarcinomas. So what are the risk factors for somebody developing adenocarcinoma or tumor of the pancreas or malignancy of the pancreas? Demographically, you look at the age, the peak incidence of this tumor is 50 to 75 years old. Most commonly, it affects the male gender and people of Black ethnicity, just like us, most of us in this who are here. So environmental factors and lifestyle, such as smoking, have been noted as some of the risk factors. Then there are genetic components. Then there are certain medical conditions which predispose you to this condition. Hereditary pancreatitis, chronic pancreatitis, and even just diabetes mellitus itself has been shown that the condition is common among those patients with this. So the clinical features most of the time are non-specific, But by the time we see these patients, most of them would have had jaundice. And at this time, they will be complaining of nausea, some gastric discomfort. They would have some pruritus. They would be passing dark urine and pus stools, pale stools, and there's steatoria. Weight loss is a very common feature in these patients. This is where Courvoisier's law applies. I hope we all know Courvoisier's law. Who's painting my slides? So, Courvoisier's law just states that in a patient with jaundice, okay, if you are able to palpate in a patient with jaundice, if the gallbladder is palpable, then the cause is unlikely to be a stone. Somebody's painting my. Who's that? Oh. So what that law just states, if you are able to palpate gallbladder in a patient with jaundice, then you should think of a malignancy as the most likely cause. So these are just the presenting symptoms and their frequency. It's just a table. I've already gone through them. You will see that most of the patients, 75% will present with jaundice, weight loss in 50%, abdominal pain 39%, nausea, vomiting 13%. So you can go through the table and to tell you the frequencies. This you can do in your own time. So what investigations are you going to do in a patient you suspect has got obstructive jaundice? Of course, you need to do your normal blood wake up, your full blood count, your U&Ds, your LFTs. You can ask for an abdominal ultrasound, and this you will look at the liver and try to look at the head of pancreas. Most of the time, imaging the pancreas is difficult with an ultrasound because of the structures which are near it. But in good hands, some people will be able to image it. So because ultrasound, the gastric and duodenal air tends to make ultrasound very difficult to image the pancreas, which is behind those structures. So if you do a contrast enhanced CT scan, you'll be able to pick up most of the tumors or the head of the pancreas. An MRI can be done, but MRI is not readily available. It's more expensive. So CT scan, I think, is more, gives you as much information. A contrast enhanced CT scan gives you as much information as an MRI. So management, unfortunately, most of these tumors present late and they are unresected at presentation. But if you pick it early, you can do a pancreatic duodenectomy, what is commonly known as the Whipple's procedure. This is a hallmark of a general surgeon. Every general surgeon should be able to perform this. For palliation, you can do a double or triple bypass just to relieve the jaundice and send the patient for further management by the radiologist. But as you might be aware, all malignancies, their primary management should be surgical. Once you remove them when they are early, then you can be able to cure them. But because these patients present late, it's very difficult to cure them. I think that's our last slide. I will give you 2 to 3 minutes to ask questions. I think we have been talking for over an hour. Yes, any questions? One hour left. Questions? All right, can somebody confirm that you are getting me?
We are getting.
Yes, we are.
Okay, since you are not asking questions, that's the end of the lecture. I think Dr. Njero will be able to send you a copy of this to one of you so that you can go through it. Have a good day.
Okay, thank you.
Thank you.
Thank you.
Thank you.
All right.
Thank you.
Before you leave, guys, Dr. Michero here. You're supposed to have the tutorial at 17. But if you look at that PDF book I said, it looks like it's main pages, but most of them are pictures. Do you think we really need to discuss if you read that on your own?
We need to discuss.
What's there to discuss, Frank? Have you gone through it?
Yes.
Tamara?
Yes.
What's your view? Isn't it self-explanatory?
It's quite straightforward, I think.
Yes, it's self-explanatory, but if we go through with you,
Yeah,
it
we
will be
need
better
to go
because you
through it.
will.
Okay,
be
so
telling
what
us
the way we are going to do it, I want you guys to be more active. So let's nominate someone who's going to go to the internet, get some good x-rays. Then they're going to lead us in the discussion. I'll be moderating. And we'll create time for that. Who's volunteering?
Frank.
Ephraim?
Ephraim.
Frank.
Ephraim has volunteered. So Ephraim is going to do that for us. So when are we
No.
going to have the discussion?
I can.
Melissa?
Yes.
Is that Melissa who has volunteered? Okay, that's
Yes.
good. So just look at nice X-ray, and you'll be the one who take us through all those steps that books are given. Then I'll add on and explain further. So when are you going to be ready?
Even tomorrow, we can do it tomorrow.
Tomorrow, okay. So tomorrow we'll arrange one lecture and also have that discussion. Eh?
Okay,
I'm
so
trying to get another lecture.
The
yes?
images will just be on abdominal x-rays.
Yes, let's concentrate on abdominal x-rays.
Okay.
You can add a bit of chest if you want, but the
Okay.
focus will be abdominal. Because there are some
Okay,
abdominal pathologies where you need chest x-ray to make a diagnosis.
Okay, sir.
All right. Okay, enjoy yourselves then. Tomorrow.
All right, thank you.
Thank you.
Thank you.
All right.
What are your problems? Your problems are not gone. Mahaka is not doing.